Hi guys, welcome to the fourth podcast of Let's Revise MBBS Cardiology, and today we are going to talk about heart sounds. Okay, so we are going to talk about 8 heart sounds, right? So which are those 8 heart sounds? S1, S2, S3, S4, and then we have ejection click, opening snap, pericardial knock, and tumor plop. Okay, so these are the 8 sounds. Now first let's see the order in which these sounds come. So let's start with ventricular systole. So the ventricle has started contracting, and just at the start of isovolumetric contraction we get a sound which is S1 because of closure of mitral and tricuspid valve. Okay, then when the isovolumetric contraction is over and when the aortic valve or pulmonary valve open, there can be sound due to opening, which is ejection click. Okay, all these sounds which I am telling you, all sounds may not be physiological. Some of them are pathological also, but I am just telling you the order in which they come, the timing at which these sounds appear. Okay, so after S1 there is ejection click. Okay, ejection click is after isovolumetric contraction, right, at the end of isovolumetric contraction. Then there is S2. S2 is closure of aortic valve, because it's at the end of ventricular systole. Okay, just at the end of ventricular systole. After S2, the sound which we get is opening snap. Okay, it is because of it is seen in MS. It is due to opening or buckling of the mitral valve. Then we get pericardial knock. Okay, pericardial knock is when the ventricle knock against the pericardium. When the pericardium is rigid or is stiff, and when the dilating ventricles knock or hit against this pericardium, then we get pericardial knock. It is seen after opening snap. Okay, then there is tumor plop. This is because of tumor like atrial myxoma. Okay, we'll talk about this later. Tumor plop, and then we get S3, then S4. Okay, so this is the order in which we get the sound. Okay, so S1 ejection click, S2 opening snap, pericardial knock, tumor plop, S3 and S4. Okay, so ejection click is a systolic sound, or it happens during systole between S1 and S2, and rest of the 3 sounds, opening snap, pericardial knock and tumor plop, happen after S2 and before S1. Okay, also S3 and S4. Also these 5 sounds occur between S2 and S1. Okay, now remember, all heart sounds are high pitched except 3 exceptions: S3, S4 and tumor plop. Okay, remaining all other sounds are high pitched. Okay, and so since S3, S4 and tumor plop are low pitched sound, we need to hear them with the bell of the stethoscope. They are heard better with the bell. Okay, so let's start with S1 heart sound. So as you all know, S1 sound is due to closure of AV valve, but what exactly happens is, first the AV valve closes and they form a triangular or a conical shape. Okay, so which is known as coaptation zone. COAP, coaptation zone. Okay, and then there is sudden tensing of the leaflets of the valve, and this tensing, when there is this increase in tension, this causes S1 sound. Okay, and in S1 there are 2 components, M1 and T1, due to closure of mitral and tricuspid valves respectively, but the difference between M1 and T1 is very short. It is less than 20 milliseconds. That's why we cannot appreciate these 2 sounds as M1 and T1 as different sound. Okay, we hear it as a single S1 sound. Now what are the things which affect S1, which affect the loudness of S1? So first is structural integrity of the valve. If the valve, how is the structural integrity of the valve? So depending on it, we can get either soft S1 or loud S1. Okay, so soft S1 is seen if the tissue of the valve, of the mitral valve, so it will be same for mitral and tricuspid, but I'll talk about mitral. Okay, so if the tissue is lost, like in case of infective endocarditis, or if the coaptation, the conical zone which is formed because the 2 valves are coming together, is not formed, if the coaptation is inadequate, that is in MR. Okay, mitral regurgitation, the coaptation is not adequate, and if the valves are calcified, Okay, so if the valves are calcified, the movement will be affected. The movement will be slow. Okay, so in these cases, if the structure is affected, then we see soft S1. Okay, and when will we see loud S1? We see loud S1 in MS. Okay, why in MS there is loud S1? See, so MS is it's like a narrow door through which the blood has to go into the ventricles. Okay, so normally if the door is wide, even if we open the door slightly, the blood can pass. But here already the door is narrow, therefore the leaflets need to move far apart for the blood to flow from atria to ventricles. So the leaflets are far apart. The mitral leaflets are far apart. And when the ventricles contract, these leaflets come from this far distance and then they close. So the distance from which they are closing is more. That's why the sound of S1 is louder in MS. Okay, this was the first thing, structural integrity. Second is PR interval. Okay, PR interval is the time after which the time between the atrial depolarization and ventricular depolarization. Okay, so if this time is short, there is loud S1. If this time is long, there is softer S1. So why is this? So see, if the timing is short, so most of the filling of the ventricles happen during rapid filling phase. Okay, so and at time of rapid filling phase, the leaflets are far apart, and then as the ventricles go on filling, the distance of the valve leaflets goes on decreasing. Okay, and finally when they are very close to each other, the leaflets, and at that time the ventricular systole happens and then the valve close. Okay, but if the ventricles contract early, that means the ventricle is contracting when the leaflets are far apart. That's why there will be loud S1. So short PR interval is seen in tachycardia, and in tachycardia there is loud S1. Okay, on the contrary, if the PR interval is long, that means the leaflets have come close before completely closing. So the sound will be softer. So in bradycardia there is soft S1. So this was about PR interval. Next is velocity of contraction of ventricles. So you can think, if the ventricles contract very fast, if the pressure generated in the ventricle is increasing in a very rapid manner, then there will be louder S1, which is seen in volume overload states like anemia, thyrotoxicosis. And if the ventricles are contracting at a slower rate, the velocity at which the valve will close will also be less, and S1 will eventually be softer. So that is seen in MI or myocarditis. Okay. And the fourth thing is premature AV valve closure. Normally AV valve should close when the ventricles have started contracting. Okay. And if they close when the ventricles are contracting, then the sound will be loud enough. But if the AV valve close before the ventricles even start to contract, then the sound will be softer. Okay. So when will this happen? If the pressure in the ventricle is higher than that of the atrium before the ventricle starts contracting. And this happens when the ventricle is getting filled with blood. Okay, getting filled with extra amount of blood. So that is seen in aortic regurgitation or aortic regurgitation with left ventricular failure. Okay, so in this condition there is premature AV valve closure, and that's why the sound of S1 is softer. Okay, now we have seen that S1 is composed of two sounds, M1 and T1, but we cannot differentiate it. But sometimes the differentiation is possible. So when will there be a wider split? That is, normally M1 comes before T1. If the timing of T1 is even more prolonged, then we will hear a split. Then we can hear a split. Normally we don't, but if T1 is prolonged, then we can hear a split. That is seen in right bundle branch block. Okay. In left bundle branch block, what will happen? M1 will come after T1. Okay. And variable split can occur in atrial fibrillation or congenital or third degree heart block, complete heart block, and ventricular tachycardia. So this is just for the theoretical purpose. Actually it is not very easy, or it is difficult to appreciate this split and all, but for theoretical purpose. Okay. And one more thing about heart sound is that it is also very difficult to differentiate between the two heart sounds, like if S3 and pericardial knock. So it is difficult to differentiate. But if we know the history of the patient, we know that the patient is having a volume overload state, or if we know that the patient is having constrictive pericarditis, then we can retrospectively try to hear that particular sound. But if we don't know any history of the patient, then it is very difficult to say whether the sound is S3 or pericardial knock or something else. Okay, so correlation with history and then listening to sound is very important, and only then we can appreciate that this is S3 or this is tumor block or this is pericardial knock. Okay, right. So we have talked about S1. Now let's come on to the S2 sound. So S2 is high pitched. S1 was also high pitched sound. S2 is also high pitched. But if we compare between S1 and S2, the pitch of S2 is more than that of S1. Okay, and S2 is due to the closure of aortic and pulmonary valves. Okay, so because of this closure, the blood starts vibrating. Okay, the closure puts the blood into vibration, and this vibration causes the S2 sound. Okay, now loudness of S2. So A2 is obviously louder than P2. Okay, because the pressure difference across the aortic valve is more. Even in the pulmonary area, A2 is heard louder than P2. If in the pulmonary area A2 and P2 are heard with equal intensity, then we can say that P2 is louder than normal. Okay, so it is loud P2, we can say. So what are the factors affecting loudness? Remember one basic dictum: if the pressure across the valve is more, or if the blood flow is more, then the sound will be loud. Okay, so whatever scenario if they give in case or in MCQs, just think if the pressure across the two sides of the valve is increased, or if the blood flow is increased, then mark loud, otherwise it will be soft. Okay, right. Now two important things: if there is aortic regurgitation because of aortic root dilatation, okay, the aortic root is dilated and that's why there is aortic regurgitation, then in that case we will get loud A2. Okay, but if aortic regurgitation is because of valvular disease, if the valve is not functioning or there is problem in valve, and because of that we are getting aortic regurgitation, then there will be soft A2. Okay, right. So now let's talk about the S2 split. So in S2 also there is A2 and P2. A2 comes before P2. Okay, and normally this split is physiological and can be heard if the patient is told to inspire deeply. Okay, in expiration this is normally not heard. So the time gap between A2 and P2 is around 30 milliseconds during expiration and 50 milliseconds during inspiration. Okay, so why is it heard prominently in inspiration? So in inspiration there is more blood in the right side of the heart, and the right ventricle will take more time for that blood for it to empty into the pulmonary arteries, and the P2 will be even more delayed. As it was late. P2 is late after A2. It comes after A2. In inspiration, P2 will come more late. Okay, that's why we can appreciate in deep inspiration. Okay, now there are two pathologies. One is wide split and one is reverse split. Okay, so how will we differentiate between these two or these three: physiological split, wide split and reverse split? So if the patient is quietly breathing, okay, quiet inspiration, quiet expiration, then the physiological split is not heard. Okay, but wide split can be heard and reverse split can also be heard. Okay, but if we tell the patient to inspire deeply, we can hear physiological split. The intensity of the difference between A2 and P2 will even be more in the wide if it's wide split, and in reverse split you cannot hear the sound, you cannot hear the split, you will hear it as single S1. Okay, in reverse split, because in reverse split P2 is coming first and then A2 is coming. If we tell him to inspire, the P2 will come late and it will coincide with A2. That's why we cannot hear the split in deep inspiration if it is reverse split. Okay, now let's talk about wide split. So wide split can be variable wide split or fixed wide split. So variable wide split is seen in pulmonary stenosis. Okay, if there is pulmonary hypertension, just think of the condition where P2 will be delayed. Okay, so in pulmonary stenosis, it will take right ventricle will take more time to eject the blood, since there is narrowing of the pulmonary the outlet. So pulmonary stenosis. Second is pulmonary hypertension with right ventricular failure. Again, same condition. If there is pulmonary embolism, okay, if there is ventricular septal defect. So in VSD, the blood from the left ventricle will also come in the right ventricle, and the right ventricle has to pump more blood, so it will take more time. And in case of severe MR, so in severe MR, what happens is A2 comes early, okay, because ventricles will empty in atrium as well as in the aorta, so it will get empty faster, and A2 will come before, like before the normal timing. P2 will be same, but A2 will come before. That's why there will be a wider split in severe MR. Okay, so this was about variable wide split. Now about fixed wide split, we see in one important condition, which is ASD, okay, atrial septal defect. Because no matter if the patient is inspiring or expiring, both the ventricles, the filling in the both ventricles remains same in inspiration as well as expiration. Okay, because there is a connection, there is no pressure difference created during inspiration and expiration, because the two sides are connected via atrial septal defect. Okay, and other condition in which we can see fixed wide split is right ventricular failure. Okay, now reverse split can be seen when the A2 is delayed. Okay, so A2 is matching with the P2. Okay, so if it is LBBB, left bundle branch block, then the A2 will be delayed. If there is systemic hypertension, even then the A2 will be delayed. If there is aortic stenosis, coarctation of aorta, in all these conditions, A2 will be delayed and there can be a reverse split. Okay, right. Now coming on to the third sound, which is S3. The cause of third heart sound is rapid. It happens in the rapid filling phase. Okay, so when the blood hits the ventricle, when the patient is in volume overload state and this high volume hits the ventricle, then the S3 sounds may occur. Okay, so S3 sound may be physiological. Physiological in children, young adults, or in pregnancy. S3 sound is normal. Okay, and it can also be heard in diastolic overload stage like MR or AR with left ventricular failure. Okay, right. And the time gap between A2 and S3, okay, A2 and S3, the time gap is around 120 milliseconds. Okay, right. So that was about S3. S4, and one more thing about S3 is S3 is also known as ventricular gallop. Okay, and S4 is known as atrial gallop. Okay, S3 can be physiological or is physiological in most of the condition, but S4 is always pathological. Okay, so when can we hear S4 sound, or what is the cause of S4 sound? So when the atria are normal and they are contracting normally like a healthy atrium, and they are contracting in the ventricles, but the ventricle is non-compliant, okay, or hypertrophic or fibrotic. So the ventricle is not dilating. The atrium is pumping the blood in the ventricles, but the ventricle is not dilating to accommodate this blood. So when this blood hits the ventricular wall, then we hear S4 sound. What are the prerequisites for hearing S4 sound? The atrium should be healthy. Okay, it should contract vigorously. The ventricle should be non-compliant, should be hypertrophied. Okay, like in case of restrictive myopathies, restrictive cardiomyopathies, in those cases the compliance of the ventricles is decreased. In that cases we can see S4 sound. Okay, and the AV valves, mitral or tricuspid valve, should not be stenotic. They should open widely. Okay, right. So two conditions, acute MR and chronic MR. In acute MR, we can hear S4 sound because the blood from the ventricle is going into the atrium. Atria is getting stretched, dilated. Therefore, contractility of the atrium will increase. Okay, that's why we can hear S4 sound in acute MR. But in chronic MR, due to continuous stretching of the left atrium, the contractility will eventually decrease. Therefore, in chronic MR, we may not hear or we don't hear S4 sound. But in acute MR, we can hear S4 sound. Okay. Now coming on to the ejection click. So ejection click is commonly heard in bicuspid aortic valve. So there can be valvular ejection click or vascular ejection click. Valvular ejection click is heard in aortic stenosis or pulmonary stenosis, and vascular ejection click is heard when there is sudden dilatation of the aorta or pulmonary artery beyond the valve. Okay, so that is about ejection click. Opening snap, we'll talk about opening snap more in MS. Here I'll just introduce you to opening snap. So the prerequisite for opening snap is that the left atrial pressure should be high, valve should be thickened. Okay, and the S2 to OS, S2 to opening snap interval is important in determining the severity of MS. So whenever you hear OS, opening snap, correlate with MS. Okay, it is in like most of the conditions, opening snap is seen only in MS. Okay, remember this. And the shorter the duration between S2 and opening snap, more is the severity of mitral stenosis. Okay, we'll talk about this more in MS. Next sound is pericardial knock. So pericardial knock is seen in restrictive pericarditis. So the as we have discussed that the ventricle hit against the inelastic pericardium. Okay, the elasticity of the pericardium is lost and this ventricle hits the pericardium. And the last is tumor plop. So there is myxoma, tricuspid or mitral valve myxoma, and this myxoma suddenly abrupts the blood flow during the diastole. Okay, it comes between the between the valves and it halts the blood flow which is happening from the atrium to the ventricles, and because of this there is a sound which is tumor plop. Right, so that was it. So we discussed 8 heart sounds. Okay, that's all about the heart sounds. See you in the tomorrow's podcast. Till then, enjoy and keep studying. Okay, sure. Bye bye.